Bismillah ar-Rahman ar-Rahim. Good evening or good afternoon or good morning, wherever you are. It's my great honor and privilege to welcome everyone in the MENASO Educational Academy Cerebrovascular Grand Rounds. Tonight, this marks the 57th webinar since the start of this series. It's held in collaboration with the European Stroke Organization. And today's session is aligned with our mission, moving from quantity to quality, with the theme of certification and a title of Setting the Standards, Stroke Unit Certification and its Impact. It's our great honor to hold this webinar tonight in collaboration with the European Stroke Organization and having eminent experts and speakers to share their insights and inputs, where together we can raise the standard and hopefully the outcome of stroke patients, not only in the region, but beyond. It's my great honor to introduce the co-chairman, Professor Selke Walter, joining us from Germany. The mic is yours, Professor.
Thank you very much. Also, on behalf of ESO, I would like to express a very warm welcome to everyone attending this webinar this evening. It's fantastic that we can join forces to develop stroke care for our patients, to improve our work and our delivery of treatments. I would like to start this evening with a little introduction about what we will hear. We will explore stroke unit certification and its impact. We will hear a very interesting talk given by Dr. Amal Al-Hashimi, presenting the journey of stroke care in the MENA region. Dr. Amal Al-Hashimi is from Oman, and she is the president of the Oman Stroke Society and is a well-renowned researcher also in that field. This talk will be followed by a talk given by Dr. Apostolos Safouris. He's the chair of the ESOStroke Unit Certification Committee. He will talk about stroke unit certification, the requirements, structural processes, and outcome quality. The third talk will be given by Dr. Alessandro Terussi, who will discuss stroke center certification and impact on advancing stroke care standards. And last but not least, we will hear an interesting talk given by Teresa Kolachna from the Czech Republic. She's the chair of the ESO Allied Healthcare Committee, and she will introduce us into what we need to know about interdisciplinary work on a stroke unit. Of course, it's always teamwork, so we are very much looking forward to hearing a little more and to hearing Teresa's perspective on that. All these topics are very relevant, and I'm sure you all will find them very insightful and very informative. Just some housekeeping rules. Questions and answers sessions will be after the last lecture, so please keep your questions, but you can also submit your questions in the chat during the talks. And now I would like to hand over to Professor Al-Hassani for the introduction of the first speaker. Thank you.
And it's a great honor to introduce my friend and colleague, who we started the journey together in the MENA over 10 years. I know Amal for over 15 years during our residency time together in Montreal. Amal is the Senior Consultant General and Vascular Neurologist and Head of Neuroscience Center at Oman International Hospital, Muscat. Amal finished her neurology training at McGill University in Montreal, followed by neurovascular fellowship. She came back and started the Oman Stroke Organization. She's the founder. She was also a board member of Oman Medical Association and member of Oman Human Rights Board. She also serves as a Middle East chair at the World Stroke Organization certification program in the Middle East. And she will talk about the stroke journey in MENA region. Without further ado, Amal, the mic is yours.
Thank you so much, Professor Adel, for your kind invitation first, and also for the kind introduction. And thank you for Professor Walter also for the introduction that she made. And it's a great honor and pleasure to be among esteemed members who's going to be also sharing their presentation with us. So if I may, I just would like to share my slides with you. So as Professor Al-Hazani said, I'm going to talk about the journey of stroke care in the MENA region. And I think we have come along very long road during the process. And this is basically the outline of my presentation. I'm going to share some data about the stroke burden in the region, and then definitely I'll talk about some of the stroke units in the region. Of course, my main focus will be among the certification process, because I was heavily engaged with the World Stroke Organization certification process lately. I guess also the publication has increased in the MENA region over the last 1 decade now, since the expert in the field of stroke has increased in our region as well. And finally, maybe we'll touch bases a little bit to talk about telestroke and maybe mobile unit. So as per the World Bank in 2020 statistics, it showed around 547 million people live in our region. And our MENA region is very diverse in terms of the ethnic, religious, and demographic composition, and also in terms of the distribution of the population. So you can find a very populated area such as Egypt, Iran, and Turkey, versus a less populated area like Bahrain, Qatar, and Kuwait. No wonder the stroke rise in our region, because a lot of modifiable risk factors and health conditions such as hypertension, diabetes, and ischemic heart disease rise. And what is really scary in our region is really that the incidence has doubled, more than doubled over the last few decades in our region, and around 7.3 million cases were reported to happen across our MENA region. And what also considered to be a concern in our region is that there is potential high incidence of stroke among the young individuals in our region. Because of all these reasons, definitely caring for building up a standardized stroke care in our region became a must and became something very mandatory. And since then, and since the return of a lot of trained experts in the field, such as Professor Al-Hazani and Professor Suhail from United Emirates, and other colleagues from the Gulf and the MENA region as well, all of us actually started to build up the stroke care. Because, for instance, I'll share my story about Oman. When I came back from my training, unfortunately, we didn't have any stroke units in the country. So I started the buildup of the stroke program in Oman. And the first unit we had was in 2013. Then that followed by another unit which was open around 100 kilometers from the first one in 2016. Then that was followed by the third one in 2017. Then another one which is allocated around 1,000 kilometers from the first central stroke unit in 2003. So those units actually catered for different number of beds, 11 beds, for instance, in the central stroke unit. In Muscat, 6 beds in Nizwa, Sohar 8 beds, and Salalah was 8 beds as well. So by end of 2018, we started having like 33 total stroke beds in the country. We are around 5 million individuals who lives in Oman, and Oman is very scattered with a lot of diversity in the geographical diversity. So we have the mountain, coast, you know, the deserts as well. And I continued to build up the service and succeeded in establish another unit in Sur, which was actually around 300 kilometers away from the original central unit, and 8 beds capacity. And the national stroke program was actually meant to build up more and more stroke units in the country. And I'm going to share some pictures with you in regards to this. So this was the very first stroke units that we had in Oman, and it was inaugurated under the partigan of the Minister of Health. And this followed by the opening of the subsequent stroke units in the subsequent years. This one actually in the preparation field visit for one of the also hospitals located in the northern aspects of the country in the process of preparation for the build-up of a stroke unit. And then by end of 2020, actually, 2022, sorry, I moved to the private sector, which is a growing health sector currently in Oman, to establish the first stroke unit in private sector as well. And this was during the launching of the stroke unit in our hospital at Oman International Hospital. Of course, the journey in terms of the building up a stroke care did not stop at this stage just by building stroke unit, but we know, definitely all of us, we know that catering and preparing staff would be the ultimate goal and standard to standardize the care in the country. And so we start with the first batch of certification for stroke nurses back then in 2004. They were trained at Mainz University in Germany, and we managed to actually graduate 3 senior nurses who to be the pioneer of stroke as a stroke nurses in Oman. And this was followed then by training additional stroke nurses nationally at the local level in the hospital. And every year we manage to train a number of nurses from all around the stroke units in the country. And this was the last batch that I trained, which was in 2023. And I'm sure the journey continued also in the government, because then I moved to the private sector to establish the stroke care there. Definitely establishing a stroke care comes also by catering also for preventive causes and risk factors, such as the modifiable risk factors for stroke. And this would not happen without the health education and launching campaigns around the country to advocate for stroke and teach the community about stroke, so that they can actually report their stroke to the nearest hospital where they get it. And in 2018, we launched also our stroke unit, and it was the establishment of stroke unit. And I'm also pretty much the similar story happened in other Gulf states as well. Professor Adil and his colleague were also stroke care in Saudi Arabia, Sohail and his group in the United States, or in the United Arab Emirates. And the journey continued. Actually, also our colleagues, Dr. Adari in Kuwait, she's doing a great job in the stroke services. Started to bloom in our region. Definitely, we wanted to have more experts in this field, so sending more individuals to be abroad and regionally as well. So the trainee trained the actually, and then we were also found this one of the papers that has been published in the MENA region by Professor Hani Arif, that looked into the care for stroke services, and this paper actually showed that there is a great diversity in terms of the stroke care across the region, because there are some countries that has developed significantly, and there are areas that is still lacking behind in terms of the prevention programs for stroke, in terms of the different acute treatments, whether it comes to mechanical thrombectomy or intravenous thrombolysis. I ran actually a survey as well across 34 hospitals in the MENA region to see how prepared are these centers in the MENA region to be certified. And this paper or this survey did help us to allocate the ready centers for the certification. And from there, we started the program of the certification with the World Stroke Organization. Our first trip was to Turkey, where we managed to assess and evaluate 2 centers in Turkey. One was in Eskişehir University Hospital, which is located 5 hours from and another and that in 2023, where there was also a recognition of that during the World Stroke Organization meeting in 2023. And then this was followed by the certification with at Azhar University Hospital. We visited another Santa University Hospital in Egypt, and we did the evaluation.
I think
it
we're
seems like I lost the connection.
Yeah. Let's try to restart and.
Yes, I'm so sorry about that. I don't know how did that happen, but let's go back. So can you see the slides?
Yes, you may need to go back 1 or 2 couple of slides.
Yeah, definitely. I'll do that. I'll do that. Okay, so as I was saying, that we started the process of the certification with the World Stroke Organization. We did the 2 centers initially in Turkey, one in Eskişehir, one in Istanbul itself. They got certified. We got the acknowledgement in the World Stroke Organization Congress in Toronto. The second round started in Egypt, where we visited 5 different centers in the first round in Egypt, where the certification done for Al-Azhar University Hospital, Tanta University Hospital, Al-Mansoura University Hospital, Alexandria University Hospitals, and these are the certification for the 5 centers from Egypt. Then the third round started, which was finished only back in February of this year. This is the certificate, the third round. We were managed to certify 14 centers all around Egypt. For instance, this is during the process of certification of Al Maadi Military Hospital. This is during our certification for University Hospital. This is Azi University Hospital. This is Al Munufiyya University Hospital evaluation. This is Asyut University Hospital, which it's located in the Upper Egypt. This is Nile Hospital located in Cairo. This is the certification for a private hospital in Al Ismailiyya. That is attached to the also Al Ismaili University Hospital. This is during our process of certification of Asr Al Aini Cairo University. This is Al-Mansoura University Hospital. We did the certification for both the stroke unit, but as well as the rehab center at Al-Mansoura University Hospital. So we came along actually with the process of certification, and currently there are around another 8 centers waiting in Egypt, and 4 centers in Pakistan, 5 centers in Iran, and we have 2 centers also in Oman ready for the certification. When it comes to the publication, definitely the rate of publication has increased lately in the MENA region, and there are a lot of good papers that has came out to tell us more about the stroke incidence, the epidemiology part of the stroke, but also the stroke care and the stroke treatment and guidelines, and these are just, I'm sharing some of the few examples that has been of the publication that has been done lately in the last 4 years, and I'm sure there are many others. Now, the next step for us actually to build up a very good system for telestroke. I think telestroke project might work very well in the Middle East. If we can have a comprehensive, that would be the dream, to have a comprehensive telestroke care system that can cater for the entire and link the entire Gulf states initially, and then we can expand to involve the entire MENA region. Mobile stroke unit, one of a kind, a unique project that has been already launched in Saudi Arabia, Kingdom Saudi Arabia, and I think our colleague Fahad Al Ajlan is the lead for this process, and we are all very proud to have the first mobile stroke units being actually into the service of a stroke, and it's been used for the first time also during Al-Hajj region, a season which is quite for the work done by the group at the King Faisal Specialist Hospital in Saudi Arabia. So we hope also that we're going to have more and more of these mobile stroke units in our region in the coming few years. These are, I'm sharing some of these pictures. Those are the team that we work with during the journey of developing actually the stroke units and centers. The top picture is with and the lower pictures with the more comprehensive sort of the multidisciplinary team in the hospital. By saying that, I'm gonna stop there, and I'll take any questions if there are any. I'm sorry, maybe I failed to give you a clear statistics about the number of stroke units or centers in the region. I looked very thoroughly numbers or figures that I can share with you. I could not find this being published. So I think this is actually we need to consider in terms of collaboration with the different colleagues and experts in the region, so that we can have specific figures and numbers about stroke units. Thank you very much for giving me the opportunity to share the journey in Oman, but also a little bit about the MENA region.
Thank you very much, Dr. Al-Hashmi, for this absolutely fantastic presentation and this very interesting talk and all the information you've shared with us. That is much appreciated. I suggest that we discuss all questions at the end of the webinar. And I would now like to introduce my dear colleague, Dr. Apostolos Zafouris, who will give the second talk of today. He will talk about structural requirements, stroke unit certification processes, and quality outcome. And to give you some information about who Apostolos is, Apostolos comes from Athens in Greece. He's a vascular neurologist, a well-renowned stroke clinician and researcher. He works in the second department of neurology at the Attikon University Hospital. He is currently serving as the chair of the Stroke Unit Certification Committee of the European Stroke Organization, and he was awarded with the Angel Spirit of Excellence at the 2024 ESO conference. And Apostolos, we are very much looking forward to hearing your talk now.
Thanks so much for this kind introduction, and thank you so much. It's an honor to be in this webinar, in this academy. So I'm going to talk about stroke unit accreditation. Are you seeing my slides?
Yes,
Okay.
very well, thank you.
So the outline of my talk will be about some data about the importance of stroke unit and the certification of stroke unit. I'm going to talk about the ESO certification procedure, some practical aspects, and finally, I will provide some guidance of how to start for an application because as you will hear at the end of my talk, we might have in the future, in the short term, some units from the MENASO area applying for ESO certification. So this is the Cochrane systematic review and meta-analysis about the importance of stroke unit care for stroke patients. It has been shown that stroke unit care reduces mortality, reduces disability in stroke patients, and increases the odds that they can get back to their homes without significant disability. And why is that? Because the steps that we take in an organized stroke unit with specific protocols result in less complications, less second strokes. And finally, what we're going to do in these first days will follow the patients in the long term and improve the long-term outcome. Because we talk a lot about acute treatments, thrombectomy, but we have to understand that this applies only to a minority of stroke patients, whereas stroke unit care is for 100% of stroke patients. And that includes patients with hemorrhage. So 20% of stroke is an ICH, intracranial hemorrhage. And for these patients, we do not have actually any acute treatment to change the natural course of the disease. But if you look into the ESO guidelines for ICH, you will see that the first line in the stroke recommendation for these patients with ICH is to hospitalize them, to admit them in organized stroke units because they improve outcome. So you may look at stroke units as the railways upon which every intervention, every treatment, every procedure is delivered in a standardized way. We're not talking about only about acute treatments of ischemic stroke, but also about measures to prevent complication, to start secondary prophylaxis and start rehabilitation. Also, any future development in stroke care will be best implemented in an organized stroke unit. In Europe, we also have huge discrepancies among different regions in the access of stroke patients to organized stroke unit care. And that's why the ESO, some years now, have started the certification process, which is an online process. A member of ESO starts this application, and if our secretary finds that the application is complete, it will be forwarded to a national auditor that we revise the application, which is mainly in English, but we leave some room for some local language documents like the logs of the nurses or the nurses training. So national auditor will run through all these documents, and if he or she thinks that everything is okay, will forward it to a couple of ESO auditors. So there might be a revision, and finally, if everything goes well, there will be 3 people that will be revising the application. Starting from next year, we will have some on-site visits in 10% of the applications, but for now, up to now, it has been only online. We had 2 levels of stroke care, stroke center and stroke unit accreditation and certification, but we have to accommodate for the revolution of endovascular treatment. Now, this is a life-saving, disability-saving procedure, and as it has been done in the United States, for example, we are going to introduce a 3rd intermediate level, which is the thrombectomy-capable stroke center, which lies between a comprehensive stroke center and a stroke unit. It provides mechanical thrombectomy, but it's not needed to have neurosurgical expertise and vascular interventions. Now, about the requirements for accreditation, there are 7 categories, and there are 2 types of criteria, mass criteria and facultative criteria. I provide a link for a practical guide for the different aspects of the accreditation process, a point-to-point explanation for anyone to download. This is free to download. And of course, for ESO, a stroke unit has to be geographically defined. It cannot be a part of an ICU. It cannot be a number of beds that may have neurosurgical patients or a neuro ICU. It cannot be part of a coronary unit, but it has to have dedicated personnel, not only medical personnel, but also nursing and therapists, SLT therapists, physiotherapists, that will show that they have experience and expertise in handling stroke patients. About the infrastructure, most of the ESO certification procedure is about standard operating procedures, SOPs. What are these SOPs? These are documents that are provided during the application. They have to be printed and present in the stroke unit to be used by the nurses and by junior doctors in a standardized way. It's about procedures that we need to follow in order not to have complications in the subacute and acute phase of stroke. And we have to document the use of these procedures. For example, from my stroke unit in Athens, this is the application that we have provided a copy of the dysphagia screening test that we are performing. This is the protocol that we have been using to treat hypertension after thrombolysis or in stroke patients that hadn't had any thrombolysis. Of course, there is no correct answer. You can have something different. To monitor respiratory function in the subacute phase of stroke, to treat hyperthermia, to treat hyper or hypoglycemia. These are the SOPs that we have provided during our certification process, because we have to realize once again that these simple measures, when done in a standardized way, they assure that the patients will have less complications and better outcomes in the long term. For those of you that are trying to complete the standard operating procedures, the SOPs for your stroke unit, there are many online sites that provide some templates. One of these is an Angel Initiative website, because sometimes it's difficult to start from scratch. Certification or not, you're going to be needing these SOPs present in your stroke unit, and you have to monitor how they are implemented in order to excel in stroke care. Some numbers, we are requiring the number of stroke patients that you have treated during the last year, how many thrombolyses have been done, and also the diagnostic tests. We're talking always about aggregate data. We're not entering into personal patient files. And of course, some of these criteria are facultative, but you have to provide some numbers. Now, if you have a local registry for stroke patients, it's easier. You may log into your registry and download your data. If you have a national registry for stroke care also, in Greece, we had neither. So we have been part of the SITS International Registry. I don't know how many of you are aware of it. It's a free to use online registry. And there we can log in and simply download the different data about acute treatment, or about some statistics about the outcomes of our patients. Another on-site registry that is free to use, more detailed and not only about acute treatment, is the rescue registry. Also there, we have been part of this. We logged in and downloaded some metrics. Now, for those of you that are not participating in these registries, I strongly suggest that you do, but it's not requisite for ESOStroke certification. And of course, in Europe, we have different things running in parallel. We have the Angels Initiative, we have SITS Registry, Rescue Registry, we have the ESO certification process. We are trying to integrate all this. And the major step has been that ESO has provided a significant fee reduction for those centers that are part of the Angels Award initiative, and they have received platinum or diamond awards during the last year. So these centers are getting a 90% fee reduction. So certification fees for stroke units is 1,500 euros. So you get a 90% of that if you have received during the last year a diamond or platinum award. Because finally, we're all aiming at the same target, which is to improve stroke care. We need to have less people admitted to basic stroke care that provides no thrombolysis. And we have to upgrade clinics that thrombolize patients to organized certified stroke units that use standard operational procedures in a regular way. We have also to develop more thrombectomy capable stroke units. And At the top of the pyramid will be always comprehensive stroke centers. This is our committee. And if you ask me if this work, the next picture will provide more data on the importance of certification. I'm only providing an example in a center in Romania where the process of getting the certification made them treat patients more with thrombolysis, have less complications, and the outcomes of patients were better. That doesn't mean that the certification process is a magic bullet, but it's a health care quality project that will improve the whole of the stroke team and finally lead to better outcomes. This is the ESO certification map of different centers. Now, we cannot expand to the west because it's the Atlantic Ocean, nor to the north, which is mostly ice. So the next step would be to receive applications from the MENASO countries. It has been a great pleasure to participate in our meeting with the president of MENASO and the executive committee of the European Stroke Organization in our meeting this year. And we have agreed upon receiving 2 applications, one from Egypt and one from the United Arab Emirates. And we hope that these applications will be fruitful and will serve as pilots for other certifications in the future. Now, if you ask me, do I have to do it? It's not an obligation. In the States, you have to have the Joint Commission be certified in order to have reimbursement. But in none of the European centers, it's an obligation to receive ESO certification. But we have many applicants because we are a non-profit ESO committee with panel of experts in stroke and years of experience. And our procedure is based in these 2 seminal papers that have been published in the European Stroke Journal, and there will be more in the way. I'm going to end my talk with an excerpt of a book that I love from Douglas Adams that describes 3 stages of human civilization. First, it's all about survival. How are we going to eat? After that, it's inquiry and philosophy. Why are we eating? And finally, it's the era of sophistication. Where are we having dinner tonight? Now, in Europe, it all started with hardly any units in many countries, and the most developed countries had a couple of units. By today's standards, there would be 20 years ago only a fraction of these clinics that would be certified as stroke units. After that, more and more treatments became available, and of course, discrepancies continued to exist among countries. And finally, we're here now where we have many people entering stroke care. Now, not providing IVT for stroke patients is considered in many countries outrageous, and not providing the option of thrombectomy is considered clearly inadequate or more. But as more and more people are getting involved, you have to show your commitment to stroke care excellence. And a nice way to do that is certifying your unit. So this is my final slide. The bottom line is, why should you apply for certification? It's a great way to improve patient care. It's a great way to standardize the way you're treating patients. What we're getting a lot from many applicants is that they lacked personnel or some machinery, and they had difficulties getting an approval from the hospital direction. When they got into the certification process and got back to the director of the hospital and told him or her that they're lacking this or that in order to get the certification, the direction was far more welcome to their demands. So it's a great way to create a team that works and boost the motivation of the staff. And you are joining a European network of excellence, and you're getting ESO support and mentorship throughout the procedures. And with that, I would like to thank you all for your kind attention.
Thank you very much, Apostros, for a wonderful presentation. And for is a European, but is one of us in the MENASO region, Dr. Alessandro Turrasi. He is a vascular neurologist in Dubai, been with us for the past few years, and he helped to improve stroke care in the region. He's a graduate from, he did his undergrad and grad study training in neurology in Milan, in Milano Bicocca in Italy, and he joined as a vascular neurologist, and he was leading also headache. He also got a master's degree in cerebrovascular disease. And currently, he is the head of neurology department at the Mediclinic City in Dubai, and clinical lead and head of comprehensive stroke program at the City Hospital. In addition to his expertise in cerebrovascular disease and headache, he's an expert also in neurosomnology and big advocate, and trained many people in the region. Without further ado, the mic is yours, Alessandro.
Thank you, Professor Adel, for the very kind and nice introduction. And good evening to everyone. Let me start sharing my screen. Okay, so tonight we're gonna try to go quickly through our journey as the first private hospital in Dubai that was able to achieve a certification as comprehensive stroke center in the region, and also to acknowledge the hard work done by every member of the stroke team across all levels of the hospital, and show how we are running now and the achievements achieved so far. Mediclinic International, established in 1983, 74 hospitals across different countries across the world, with 7 hospitals in the Middle East and 28 facilities, all GCI accredited. Mediclinic City Hospital, where we work currently, was opened in 2008 and started the process of stroke care in 2016. And we were able to achieve the first level of certification as a stroke unit with dedicated stroke beds in 2018. And then later on, we were able to achieve certification from the American Heart Association as the first private hospital certified as a comprehensive third level stroke center in 2021. This is our journey. As I was just highlighting now, we started with a more humble project about stroke care. Then we certified the stroke unit service for intravenous thrombolysis. And then we were able to start in 2019 a neurointerventional process with a mechanical thrombectomy and an interventional neuroradiologist on board. We worked on our reviews of the guidelines and KPIs, and with the support of the MENASO and the HA, we were able to apply for certification, which we achieved in 2021. And just recently, we obtained certification in 2024 as the first comprehensive stroke center in the region. The other comprehensive stroke center is the Rashid Hospital, the governmental hospital. And so far, we are the only 2 certified comprehensive stroke centers of the Emirate. This is our team. Just to say thank you to all the team members, the ones that are in the pictures, the ones that are not in the pictures. Some of them they left, some new colleagues they joined. But our thanks to our excellent ID team, ICU team, our neurointerventional team, and Dr. Papa, the radiology department, the inpatient setting, the rehab, a neuro rehab team with speech therapist, occupational therapist, and neurophysiotherapist that help us achieving better results for our patients. Of course, the process to become a center of excellence starts with an induction program, and you need to dedicate time to build up a system based on evidence in clinical care with patient safety as item number 1. You need to be able to find KPIs, and you need to start auditing your processes. Then you can prepare your clinical program and apply for accreditation or certification to become a center of excellence. We prepare the review guidelines. We go through regular cyclic guidelines reviews and reassessment and republication for our internal pathway and policies. And this is our stroke protocol, our code stroke system. Patients are triaged with BFAST unless they are already referred as a code stroke from the EMS system. We activate code stroke, which is announced loud. CT scan is kept free and available. We do CT, CTA, and CTP for all our cases. The ED doctor is leading the case in direct connection with the neurologist. We will jump on board as soon as possible. And the radiologist, we go for rapid AI assessment for any large vessel occlusion and CT perfusion data. We provide intravenous thrombolysis directly in the CT suit. Now we've got tenecteplase, which will allow us to go this way. And if there is an LVO detected, we activate the interventional neuroradiologist, the cath lab for mechanical thrombectomy, to be followed by ICU admission and stroke unit admission in the ICU. And we start the acute stroke process and the neurorehabilitation process. We started with a certain number of KPIs, and through the time, we increase them, because this is one of the main advantages and perks of going through a certification process. You try to benchmark your parameters and your performances. You've got KPIs from, for example, DHA in this case, and then you start adding additional KPIs to do even better and better. So we added also the governmental KPIs, like the door to ED, door to neurologist, door to CT, and we capture and we benchmark all these 22 KPIs in the acute setting. It's important to have a roadmap, a road plan, a strategic plan that we review every 2 years. And this again is part of the mindset when you have to go through a certification process. And we review this roadmap biannually, every 2 years. We collect, of course, data about the number of stroke cases we receive, the mode of presentation, if they are ischemic or hemorrhagic, the number of thrombectomies, and we analyze them. We've got a large database and registry capturing all the data, plus participation to the SITS registry. Being a part of a certification process and being certified stroke center means that you have to provide continuous education in order to maintain your accreditation, of course. So we developed a program of education for healthcare allied professional, non-health allied care professionals, doctors, nurses, receptionists, and so on. In terms of stroke education, we provide NIH SS refresh courses every month. We do stroke workshops and training also on the electronic healthcare system, so that we don't have surprises running a code stroke in the acute phase. We do a stroke workshop for nurses every year with 8 hours of clinical and rehabilitation education. We do NIHSS training for doctors and nurses multiple months per year. We all completed a provider ASLS, so Advanced Stroke Life Support provider course for all emergency department and ICU doctors, and for all emergency department and ICU nurses. All our nursing staff in the ICU and the stroke unit are Angel Stroke Nurse certified, and we also run stroke simulation programs every year. This is an example of our stroke workshop that we run, and our ASLS Advanced Stroke Life Support provider and instructor course. We were the first facility with an activated teaching center for Advanced Stroke Life Support. And these are our sessions when we train providers for our hospital, also for other facilities and other institutions, and then we measure and we keep track of our KPIs. This is important to be sure that you are following the guidelines and the protocols, that your interventions are effective, but it's also important to be able to highlight or to find out when and what is going wrong, when you are not successful, to try to implement corrective measures. And these are some of the KPIs that we collected, and some of them not so great sometimes that require corrections. These were from 2024, and we implemented correction measures, for example, for CT scan, faster access to be able to achieve more successfully door to CT. Of course, we collect ortho CT and MRI, so the overall time can be sometimes less than amazing, but when you separate CT from MRI, the numbers, they do improve. The other important thing is that you will see through a certification protocol when you are improving. And for example, we saw a dramatic improvement when we transitioned from intravenous alteplase to intravenous tenecteplase, cutting down by half our door to needle time. The other big challenge is the standardization. This is fundamental in a process of certification. We should all talk the same language. The protocols should be easy, clear, and simple to follow by everyone, and should be absolutely standardized. So we had to move from a paper-based system to a electronic healthcare system. So we implemented a stroke pathway in electronic form with an IHSS and all the inclusion criteria for thrombolysis, thrombectomy, the last well-known time, and so on. So we can produce always standardized data also for later collection and review. And the same was for education. So we prepare QR codes for educational material to be disseminated to patients at the time of discharge or during the hospitalization for caregivers and for family members. Part of the stroke certification process is to have quality benchmarks and quality improvement initiatives. So we prepare as a timeline and a time course of quality improvement initiatives from internal improvements like improving compliance to the EHR system, improving the quality and the time to radiological reports, education, discharge for the caregivers and the family members, and part of the quality improvements had also the involvement of the education component. So we started also running educational events to increase awareness among the population, from Walk for Stroke and meetings with the physicians and the experts to try to engage our community. Part of the certification process is to try to boost research and participation to studies and education. And we tried, and we still try, we are now trying to finalize our paper with our stroke registry. And it's fundamental to have collaboration, because another very important point of certification process is that it allows you to connect with other institutions to improve collaboration between hospitals for the best interest of our patients, with the society, with the scientific societies, with the EMS system, and the government and the institution of your country. So going to the conclusions, take-home message or messages. Well, the first point, the most important one, is that once you are able to apply for a certification process and you start and you achieve that, you are trying to commit to improved patient outcomes and improved safety. Certification enforce the adherence to evidence-based protocols and reduce the number of errors, improve the outcomes, improve the number of lives saved and disability prevented and reduced due to faster door to needle, faster door to thrombectomy, and better also complication prevention. It does guarantee a structured multidisciplinary collaboration, so that it's a way to bring together specialists and professionals of different, coming from different backgrounds, physicians, nurses, rehabilitation specialists, DMS team, and it has to be done in an audited way. So everything will be recorded and will be benchmarked. This is the most important point to remember. Reduce the protocol breaches and the human mistakes, because you are following guidelines and not mind lines. It allowed the center to become a center of reference for the region, for the area where you are working, improving patient trust and confidence because you know that you are reliable, you are following international standardized guidelines, and also research collaboration. It push and makes a big focus on continuous quality improvement, education. You have to follow and to measure your KPIs. You have to follow and review your audits, and you have to benchmark continuously against yourself and the best international standards. And it allows professional development and academic growth, giving opportunities for research, for teaching, and for publication, becoming a platform of collaboration and also of training. If I've got a few more seconds, I will just show, if you can, the video about our stroke center at Mediclinic City Hospital here in Dubai. This is the journey of a patient reaching our ED. NIHSS is collected at admission with all the vitals. Our electronic healthcare system where we document all the findings. Code stroke is announced. CT scan is kept available for the suspected code stroke. CT angio and CT perfusion are immediately performed, imaging reviewed, and thrombolysis is started. And cath lab is activated if there is LVO for mechanical thrombectomy. Dr. Rosario, our neurointerventional radiologist, interventional neuroradiologist. He will kill me if I say it wrong. Patients admitted in the stroke unit beds. Our ICU doctors and medical ward, hospitalists and physicians. Our education protocol for family and caregivers. Neurosurgical consultation when it's necessary. OPD and physiotherapy management. And this is the neurorehabilitation department. Thank you everyone for the attention.
Well, thank you very much, Dr. Teruzzi, for this very, very excellent talk and for presenting your impressive work. Especially this last video was very nice and very nicely also introduces our next speaker. If I may go on with today's program, I would now like to introduce Mrs. Teresa Kolachna. Teresa is a nurse by background. She has dedicated more than 25 years of her career to stroke care and neurointensive care. She works at the Motol University Hospital in Prague in the Czech Republic. And she has served as a head nurse of the neurological intensive care unit for more than 1 decade before she was appointed as a head nurse of the entire neurological clinic. And this position she has held for the past 3 years. She is very committed to education and professional development. And today she will speak about the interdisciplinarity in stroke care and on stroke units, something that is absolutely needed when we want to deliver high quality care. Teresa, the floor is yours.
Oh, hello everybody. Let me share my screen. So can you see my screen, please? Now?
Yes.
Great. Thank you very much. So hello everybody. I'm Teresa Koláčná, head nurse of the neurology clinic here in Prague, in Czech Republic. And I am hugely honored that I can speak in front of you about something what's essential for work of all of us, because collaboration at our field of work, its stroke unit, is essential. It's an essential part of all of it, what we do. So what's the key role in the collaboration at the stroke unit? So yes, that's a team. Without proper team, the collaboration is without logic. I will describe this team later because it has lots of persons which should you have, but you should have less, you should have more. But basically, that's those what I will mention are those who are essential. Then second point is a cooperation itself. It has to have the rules. It should be not by just logic. It should be made up. It should be benchmarking, as my previous speaker said. Then very important point, are competencies. Competencies means what each of the profession can do, where their competence start, where they finish. What's very important that everybody has to know these competencies in care or in therapy, it doesn't matter, but these competencies has to be laid completely clear, because we have to know the place where we start to work and when I finish my work and put it to another person. Another essential form is communication itself. Communication is something what's easy, but definitely it's most often in communication we make most of our errors. The communication has to be clear, has to be simple, but not be. It can't be too big, too complicated, because then should mistakes happen once again. I will speak about some of these communication errors on the end of my speech. What's very important is that we have to create meetings. Meetings are places where we share information together, and they are like essential part in the cooperation. On this place, we start to really cooperate. So it means I have some information, you have some information, let's share them and make a plan how to make our cooperation better. Yes, the nurses, for example, they have meetings twice a day, because when they changing shifts, that's small meetings, nurse to nurse, and they changing the information about the patient, how he is, what's her needs. Department nurses, it means head nurses of units, meet every single day. So it means every single day, department nurses of all departments in my clinic meet, and we discuss problems of our patient, our departments, and we have to collaborate together. Physician and nurses in my department meets daily, but their meetings are more informal, because every time the doctor or physician meet a nurse, they make small meeting, they solve the problems of their patient. Very important part are meetings with the physiotherapist, with speech therapist, with occupational therapist, those professions where we need to share our information and we need to continue in the line of the care. But where this cooperation or collaboration in stroke care start? It starts on the start, with the stroke of the patient, because that's a beautiful process and quite simple one. How collaboration works? Yes, on the start is a stroke of the patient. It leads to that somebody, family, anybody, call paramedics, and then collaboration on the level of our professional start. It means paramedics should call the center and just inform them. I think I have a patient who's probably stroke patient. And it leads to fast transfer to the hospital, fast transfer to the stroke team. In the hospital, fast track to the radiology, fast track to laboratory, and fastest track to it doesn't matter, thrombolysis on other type of the therapy. That's a simplest and very nice example how collaboration work. If in any of this triangle is some error, it make a delay, and delay leads to worse outline of the patient or outcome of the patient. So it means, yes, after thrombolysis, we admit the patient on the stroke ICU. And I'm very happy to say that here in Czech Republic, average time from doctor needle time, from admission to therapy time is 20 minutes. It means usually we are better, sometimes we are slower, but reasons are different. And yes, that's basically like pre-stroke team pathway. Now to the stroke team. Stroke team, as I says, it has multiple persons. Our brain, our head is physician. He is the one who leads the cure therapy, but without 8 others, it's just only therapy. It's not enough. There is much more. Second in the line is nurse. There are lots of type of nurses here in Czech Republic and all around the world as well. But let's say general nurse, something what we can say we are hands of the doctor. The doctor think out how to cure, how to do a therapy, but the nurses are those who just do the hands, prepare the infusion, prepare the thrombolysis, and do it. Sometimes we are not just only hands, it means passive role. I am not the one who think it out that this patient need thrombolysis. So that's a passive role. I am the nurse who do the medication passively. But I am active member of the team as well. I am, no one need to say me how to take care about the patient with the dysphagy, because that's a care bundle. I know what to do with the patient with the dysphagy, how to do it, or how to prevent bed sources, for example. That's my active part of my position. So yes, sometimes I am not just only hand of the physician, I am also something like neck of the physician. I can slightly turn the head of the patient, of the doctor, and says this patient has slightly more problems than just, for example, stroke, but it doesn't matter what is it. So very important role of the nurse. Nurse is a passive role. I do what the physician needs, and then active one. I am the nurse who know needs of my patient, and then I continue in my care. Then there is a very big group of the people which we call in general nurse assistants. These are slightly less educated healthcare professionals, but they are very needed. They take care about the basic human needs. They like washing or in the bed or positioning. But these people spend with our patient very huge time, and they have lots of information. And these information are needed both for nurses and the physician as well. So that's a very good source of information, and we need them and use them a lot. Then there is a huge group of the physiotherapists. Those we have because they are focused on regaining physical function and mobility. They spend less time with the patient. In Czech Republic, usually once a day, sometimes twice a day, it depends on their needs, but usually once a day they spend some time with the patient. They are very needed, but they do not spend a whole day with the patient. Speech therapists, another group of the people who take care about the speaking disabilities and swallowing disabilities as well. These professionals are very, very needed because on their advices, we know how to continue with basically swallowing disorders, because they are for us nurses most potential dangers. But in the logic of the speech therapist, in the speech, we still like cooperate, coordinate the care with them. We continue with their work. It's the same with the physiotherapists and speech therapists and occupational therapists as well. They spend with the patient some time. The nurse assistant and nurses continue through the other time, which through whole day, whole night, because just half an hour of time, what the occupational therapist has a time for this patient, it's not enough. We have to continue, we have to collaborate. So it means we have to gain as much information as we can and then continue in their work. Then there is a home service. That's something for a physician is completely invisible. Those are those who help us keep our department as nice as they can. These are very important part of the stroke teams. Those are usually ladies who has a time to speak with the patient, just chat, and usually our patient mostly very nicely confide to these ladies and inform them of their problems. Those problems, they don't want to worry us, the professional, with their worries. But this lady is not professional, so information from these ladies are very, very important in arranging the whole system of the care in the logic of the holistic care of the patient. Dietitians, that's a profession which help us solve dietary needs of the patient, and it's not just only consistency, it's a special needs, diabetic diets, and also all these problems what should occur in the care. Social workers, we have to plan. We have to plan what will be after hospitalization. With hospitalization, the work do not end. We have to continue. The social worker help us solve the social situation after admission of the patient. So it means they provide support for patient and families and assist with discharge planning. The psychologists and the spiritual care, both of them are very needed. Once again, the holistic approach to the patient is a main issue of the whole stroke team. If we treat just only stroke without all of this, then we treat just only stroke, not the patient itself. And the patient itself is the one who is needed. This diagram shows how it stands in my point of view. So center is a patient. So it means that's a center position for my work and work all of us. But not all of us are standing in the same position like other. So it means closest to our patient, even he is alone in the hospital, is still family. He brings his family in his memory, in his everything in mind. So we have to still cope with the family, and we have to collaborate with the family itself very closely, because after the mission, the patient will continue in his normal life with his family, with his normal surrounding. So the closest to the patient is family and the closest person itself. Then there's then a nurse, the one who spent most time with the patient, who has unique position. Because even the, for example, nurse assistant who wash the patient, turn the patient, feed the patient, do lots of these basic tasks. Sometimes can spend more time with this patient. The nurse is the one who asks this nurse assistant how it goes. Say me, does it goes as normal or there was some problem? It's same like with physiotherapists, occupational therapists, speech therapists, everybody. Because she needs to know the result of their work. And nurse is responsible to send it to other profession. Nurse is the one who advised nurse assistant, please be careful with the feeding. Do this patient has a dysphagia? Please, do you do everything correctly? Do you know what you have to do? She's the one who is responsible. Attending physician is little bit far away from the patient compared to nurse and nurse assistants and other professions like physiotherapist, occupational therapist, speech therapist. He knows a patient quite well, but from the point of view of the stroke, of the diseases, not the stroke itself, but diseases, and do not spend in general so much time with the patient compared to other professions. This attending physician really definitely need a nurse to pass information to other profession, and she need information from the nurse to know how it goes. Consultant physician came just from time to time when it's needed. and solve just one very specialized problem of the patient. It should be complex, but specialized one. So it means that the nurse is the one who is essential in this process. When the nurse fails, the whole system will be problematic. It means do not run smoothly. I think all of us know situation when something happened and information get lost. And we very painfully and slowly regain it back. That's something, and I can say that I know that the nurse do fail. She do not pass information correctly. So, which team barriers I feel in communication in some teams are most powerful? First of all, it's a hierarchy. Hierarchy is problematic. Imagine that, for example, some nurse assistant knows very important information about the patient and it's scared to pass it to higher level because of, I don't know, something. They are shy. It should be. This hierarchy is complicated and sometimes we are lost in this hierarchy. We have to know our place. Then there is a jargon. Jargon is sometimes I can see hell because I think that I pass my information correctly and the second person do not understand me because I use jargon. That's something what I strongly advise never do. Please never use jargon in any rate because failure should happen very easily. Then there is something what we have to have in mind. Nonverbal communication is every time stronger than any verbal communication. So if you misinterpret nonverbal communication, you should make a huge mistake. So please be careful how you communicate by your body. Your body is every time more powerful than your speech. If you are bored and you are passing very important information, the information will be you are bored, not what information you pass. It should happen that the whole team communication will be ineffective. So it means there should be too much, too less information. It do not work smoothly. That's something what you have to focus on. It do not happen in a whim. We have to work on it. We have to create it. We have to cultivate it. It's something what we have to work for it, and it's usually work of the head workers. My work. Then if you have problems in communication, then some trainings are needed. And if they are insufficient, still it's a work of your chiefs. You have to be trained how to communicate freely. Then there is a problem. On one hand, we have lots of electronic devices. On the second hand, we still sometimes write. And if you something write down, it has to be readable. If it's just scratch on the paper, then it's not enough. Information overload means too much. If we are lost in information, it's not good. It should happen that we should be completely just stressed, just fatigued. It should happen. Be careful when you feel it. Take a break. That's what I says. Problem with the technologies. Technologies should help us. On the other way, I know multiple times when the technology fail. That's a barrier, huge one. And if we do not involve the patient in our system, then we make a huge mistake. So how to say it in one slide? Essential is, please try to do as effective communication as you can. Everybody has to know their role and their competencies. Please make regular team meetings. Involve family. Those are the keys for good collaboration. And don't forget, nurses knows everything. Thank you very much.
Thank you very much, Teresa, for a wonderful, wonderful presentation. Highlighted the importance of teamwork, collaboration, and communication. As you all are aware, it takes a village to care for stroke patients, and on average, they see between 10 to 12 healthcare practitioners. So it's important for all those team members to work in harmony. Please join me to thank all the presenters for an outstanding presentation and great work trying to address different aspects of stroke unit care and certification. I'd like to invite all the speakers to please turn on your cam. I don't see any questions in the Q&A, but I would like also to welcome a special guest who's near and dear to my heart, who was really key person behind this collaboration, and he always works from behind, but his work is remarkable and noticed. Professor Ahmed Abdel Alim, he's the Vice President of MENASO. He'd been with us, and he was the mastermind behind the MENASO collaboration. Prof. Ahmed, if you can turn on your mics and give us your feedback and insights to this session.
Thank you, Adil. It's a real pleasure to see that we are moving forward with our collaboration with the ESO, and this time it's a really interesting webinar because we are talking about the accreditation. This kind of webinars are really like inspiration for the region to be able to move forward with certification. And the most important message I think I would get as a viewer of this webinar is that certification is not an option, it's a must. It's an essential part of the stroke care and the process. So that when you establish a unit or when you start a service, you should be keeping in mind that certification is the only guarantee that you will really provide your patients the right service, right time, with the right hands. So thanks again for the ESO for supporting this message. And of course, I thank Apostolos for his always inspirational speeches. We have already gave one in one of our conferences in Egypt, and we will be looking forward to collaborating with him and the ESO on the certification. And of course, I thank all the speakers for this really, really amazing speeches. Dr. Amal is already an expert in accreditation, and also Alessandro have been giving really the fine details of the pathway that he went through to get the accreditation, and showing that there are fine details that you should be taking over or looking for. As for Teresa, I really thank her for showing us this perspective from the service. I always say to my team in Cairo University that if the doctors are the heads of the service, but the nurses are the heart of the service. So it cannot operate without them. They are part of the team. They spend most of the time with the patients. So we really should be keeping in mind that nurses should receive good training, should always listen to them, see their perspective, and that's one of the ways that we all as a team reach what we all need to look for. And of course, I would like to thank Dilka for her continuous enthusiasm about making these collaborations, and we will always be looking forward to the next meetings with the ESO. So thank you very much.
If I may, thank you very much also from our side. It's fantastic that we have managed to start this collaboration, and it's very inspiring. And I think this evening has again shown us how much we can achieve together. Thank you to all these fantastic speakers. Every presentation was absolutely very interesting, and I was deeply impressed by all the very excellent work you've presented. If I may, I would like to ask one question to Dr. Amal Al-Hashmi. You've presented very nicely that stroke units and establishment of stroke units is absolutely needed. We all know that. What do you think? What are the biggest obstacles?
Well,
when someone now hears, maybe someone is listening who thinks about establishing a stroke unit, what does this person need to consider?
Well, thank you, Professor Walter, for your kind words. It was a great honor and pleasure to be among eminent speakers tonight. Thank you for Professor Ahmed as well. and for his kind words. I really enjoyed the presentations delivered by the other speakers as well. So yes, I have to tell you, it's not easy to start the stroke care. However, it is something that would require the main obstacles about starting stroke care. It would require a multidisciplinary approach, and this is quite expensive because often the administration would argue, why would you need specifically a speech therapist or speech pathologist to cater for stroke units and not something to be shared with the rest of the hospital or occupational therapy? So I think the main thing is building up. The main obstacle and the main challenge in starting a stroke unit is not finding a geographical space in the building. This is probably the easiest things to happen, but rather building a multidisciplinary team that cater for stroke care and work with one united spirit, which is basically raising the standardized of care for these stroke patients. So this is one of the things that I faced initially when I started founding the program for stroke in Oman. They used to argue with me, is like, you know, this work cannot be done just by the doctor and the nurse, and it's like, no, it would require more collaboration and collaboration among the different multidisciplinary approach in terms of different specialties in the team. The other thing is probably, which we at our region is a little bit lacking behind, is we have achieved so many things in the hyperacute phase in terms of stroke care. However, we are still, I think, lacking behind in terms of rehabilitation. So I think working on the rehabilitation as a very solid pillar in the improvement of stroke would also something that we struggle with, and we need to work more to kind of improve it in the future. The nice thing about our care system here in Oman is that we have community nurse that can actually cater for stroke patients even after their discharge. So I think this is one of the things that needs to be also encouraged and built in the rest of the system. One more challenge that we could face in our region is because of the fragmented health system, because there are different sort of bodies that actually deliver the stroke, the care in the Gulf states. So it's not just the Ministry of Health, but it's rather the army. They would have their own. Then when we have the royal and diwan, and we have also the private, and then we have the government, we have the university hospital, and they are not well integrated or connected. Although I have to say we have achieved a little bit of progress in the last few years, but I think there are still gaps to be actually closed in order to achieve more in stroke care.
Thank you very much. I totally agree. If you have to kind of join different institutions, societies, key holders, that is quite difficult. That's a huge challenge. And actually, I find, Dr. Turutsi, you've presented that very nicely, how you've managed to bring it all together in your hospital, especially how you established a really structured educational process. That was very interesting for me. Would you like to, or would you be able to give us some insights into your simulation training? Because personally, I find sometimes, you know, we all have to attend these mandatory hospital trainings, and then you find it quite boring. But simulation training is always something catchy and can be quite interesting and can make it easier to convince people to really attend.
Yes, thank you, Professor Waiter, for the question. I agree. It's a challenge, education, but it's also very rewarding, because the moment you see that people start understanding, this is the most important element from a clinician point of view. You want to have your colleagues, the juniors, the hospitalists, the nurses, everyone to understand why they are doing certain things. What is the added value? Why you have to check the blood pressure or the NIH every 15 minutes? Well, there is a real necessity, and you start educating them about time is brain, the penumbra, all this information. Then they start making sense. It becomes reasonable. Oh, I have to do this because this brain is losing this much and much. And then you push. And the 2 minutes that you can cut in the time to CT, they becomes valuable in everybody's eyes. And I think this is one of the most important elements of education. So it's not just sitting, listening to someone talking, but is trying to provide the understanding of the rationale behind our actions and our protocols. And this does bring people together. And I think this is very, very important. It's not easy. It's a learning process, even for us. We improve every year, and it's always a learning journey, basically.
Yeah, I totally agree. That's right. And we will have to walk that journey. And that is what makes our job so very interesting. And Apostolos, I think we had one question addressing the different backgrounds for the different stroke teams receiving certification or proposing stroke unit certification. And I think the question was around the English language as common language. Do you want to repeat your answer, which I think is quite important to mention, that of course we all come from different countries, we all speak different languages, but at the end of the day, we need, and that was also very nicely presented by Teresa, we need to speak the same language.
Yeah, it's true. And taking into consideration that the new Apple earbuds are not going to provide real-time translation for every language in Europe, we still need to have a language. I mean, we are part of a team. We are 12 people comprising the committee from different countries. So we need two people to provide objective assessment. So the only way to do this is by using English language. Now we understand that some documents, especially the training log of nurses or some protocols nurses may use, might be in local language. That's why we have the national auditor for that. But for the time being, at least, we have to have most of the documents provided in English in order for us to be able to revise them.
Yes, thank you very much. I think that is very understandable. What do you think, if I may ask one further very short question, what do you think, how long does someone need to plan? If someone starts from scratch and wants to receive put in a proposal for a stroke unit certification, what would you recommend? How many people do you need and how much time do you need to prepare?
Well, the question about the number of people needed depends on their motivation. Usually there will be one leading this effort that will be the one also to submitting the files and also responding to questions. So you have to have at least one that is the leading the application. Now, how much time do you need if you start from scratch? You're going to be needing some time. I'm afraid you have to show that you have been using these standard operating procedures for some time, and you have to provide some data on the past year. Of course, this data need not be prospective, so it doesn't mean that you have to wait a whole year for applying. You can go and submit retrospectively gathered data, but you have to have at least some months of using these protocols and showing that there is a team that has a standardized way of working with stroke patients. So I would say that at least you need some months. Now, if you are a unit that already uses these protocols and SOPs in their everyday clinical practice, you can retrospectively provide this data. So it wouldn't take more than a couple of months to complete your application if you have already some SOPs in work.
Thank you. Dr. Al-Hashmi?
Yeah, I'm actually interested, if you would allow me just to ask one question. I'm really interested to know the fees for the certification. How much does it cost to do that? As a matter of fact, I have long list of centers that are eager to get the certification around the MENA region and also beyond the MENA region. So if you can just spotlight upon that, I would be very grateful.
The fees for the stroke units is 1,500 euros, and for stroke centers is 2,500 euros. Now, there are reduction in the fees for low and middle income countries. And there is also this reduction of 90%, so that translates into 150 euros for the stroke unit if you have an Angels initiative in your country and you have achieved diamond or platinum status at least once during the last 4 quarters of the last year. So this incites a lot of centers, because in Europe also for public hospitals it is difficult to get this funding for a project that is not, an obligation of the hospital, of the medical director. So we think that with this reduction we would have more applicants in the future, reduction in the fees.
Thank you.
Thank you. If I may, I think we've got one question coming from the audience, and the question is whether there are any courses and suggestions in managing stroke patients for interns and junior doctors, so education for junior doctors. I can say from an ESO perspective, we've got for ESO members, and ESO membership is free for everyone up to the age of 35 years. And we've got an online learning platform, which is called eStep. So access to that learning platform is free. And I would like to hand over to Professor Al-Hassani to answer that question for MENASO.
So just want to make sure that my mic is working. So this is the 57th webinar. This is around the certification, but there has been many educational, grand rounds covering different aspects of stroke, and they're free through our websites and through YouTube. It talks about different aspects of stroke care, and they're very useful, across all the continuum of, healthcare professionals. We also do 2 to 3 courses. We call them, it's like a boot camp done at different countries. And also we hold our annual meetings where, next year, inshallah, we will be in Kuwait. So there is all sorts of activities. And for the previous webinars, as I mentioned, it's available online. And our membership is also free, and you can get access to all those resources and announcements about future resources. So please join us. I think we are past our time, but I'm sure this, webinars and grand rounds strikes a lot of questions and inquiries, and hopefully we'll see more and more people coming for, certification. So with that, I would like to thank our colleagues and partners in the ESO and speakers, all the speakers, and you, the audience. The mic is yours, Professor Walker.
Thank you very much. Also from my side, a huge thank you to everyone who participated today. We very much appreciate your time and your engagement. And we all believe that your commitment will strengthen our community, and also only together we can drive this mission forward and advancing stroke care in both regions, Europe and in the Middle East. And we hope that you have found this session very valuable, and we are very much looking forward to seeing you again, hopefully in many more upcoming webinars. Thank you again for attending.
Thank you very much,
Thank
everybody.
you all.
Thank you.
Bye.
Bye-bye.
Thank
This
you.
webinar is going to be around MSU, so we look forward to that. It's going to be announced, so please stay tuned, and good evening, everyone.
Bye-bye.
Bye-bye. Bye-bye.